So good afternoon, I'm Rehan from Emergency Department at Royal Prince Alfred. The topic of the talk, I was asked to teach about C3000. My thinking is that the knobs and things on the ventilator machine is fairly self-explanatory. What we need to do first is to go through that what we do, why we do, and what's the physiology behind it, just the very basics. Nothing too difficult, and just to go through the ventilator, that why we do what we do and what's the evidence behind it. So the topic that I've chosen is think, exhale, and that essentially, I think, explains the whole of the physiology about ventilators. So what do we mean by this? What do we mean by this is that if we have taken control of someone's respiratory system and we are pushing air in, we should give him enough time to expire. In other ways, there are two goals in my mind of putting someone on the ventilator. One is a mechanical goal, which is the air goes in and we let it out. We let it out because expiration is a passive process when someone is tubed and when someone is normal as well. Whereas inspiration is an active process where with positive pressure ventilation the air goes in. So the second goal that when I think of ventilation, apart from the mechanical physiological aim, is physiological aim, which is oxygenation and letting the CO2 out. So oxygenation should be the prime importance, and we'll talk about carbon dioxide, that how high is high and how low is low and what we should be aiming at. So think exhale always when you are changing settings on ventilator, when you're tubing them. So let's go further on this. So the simple law is think exhale, and what we can play with to let people exhale is the pressure, is the volume, the flow, and the time we allow the air to go in and the time we allow the air to come out, which is called IE ratio, inspiratory to expiratory ratio. Why pressure? So pressure means that we are asking the machine to give a set pressure onto the air going inside the lungs, distending the lungs, and then let it come out after a set inspired time. This means that the air going inside the lung, the volume of it will depend upon the distensibility of the lungs to that given pressure. So that is the basics of pressure controlled ventilation, that you are dialing up a pressure and the volume will be variable dependent on patient's compliance, where compliance is distensibility of the alveoli. The second part is the volume. The aim of both of these is the same, to give an amount of air into the lungs, depending on what you want, what method you use, and how much to give. We will see that in a moment. Flow and time we'll go through when we go through the expiration. So these are just a couple of things that I have listed here, which are just a sort of a thought provoking things, that whenever you are putting someone, or when you are thinking of artificial ventilation, that what should you use? Should you use non-invasive ventilation strategies? Should you use intermittent positive pressure ventilation like tube them? Should you use a general intubation strategy? Should you use a lung protective strategy? After learning all these, what disease specific things you need to know? How to ventilate someone who's got asthma, how to ventilate someone who's got chronic obstructive lung disease, or ARDS, or is in acute pulmonary edema so bad requiring intubation. How to ventilate someone who has had multiple trauma with head injury possibly, or with traumatic lung injury. How to ventilate someone who has got isolated head injury and has got raised ICP or a subarachnoid hemorrhage possibly. How to ventilate someone who is pregnant. How to ventilate someone who's got an acute compartment, abdominal compartment syndrome. This just means that they've got an acute tummy or a raised pressure inside the tummy. Okay, so these are the things we need to know as emergency physicians, because these are the extremely common scenarios which we come across in our daily life in ED. Going further, there are a couple of things that puzzle us all when we stand in front of the machine. When we turn on our C3000s, as in our ED we have got Oxylog C3000 and C3000 Plus, and whenever we turn them on, the pressure time graph is the default graph that it defaults to. Question is, should we learn that? What's the benefit of learning that? Or should we switch to something else that is easy to learn and gives us much more information? Is the floor time graph. How to switch to that? An end-tidal CO2 should always be there onto the monitor, and that will give us quite a lot of information as well. In this talk we are going to talk about floor time graph only. And why? Because I think it will give you a lot of information, and you can titrate your settings to that information and make a safe strategy for the patient. So we're not going to talk about pressure time graph, we're not going to talk about end-tidal, we're just going to talk about flow time. Stepwise approach to hypoxia. This is something that one should write down on a piece of paper, that what they are going to do in what stepwise patient if a patient is hypoxic, either tubed or untubed, and should have separate strategies for both. And stepwise approach to hypercapnia, this we will learn today. This we will resort to another time. Now, volume. So the first question always comes to mind with an intubated patient, that how much volume should we give? We now know that we should titrate our volumes not to a physician's choice or not to a number, and titrate it according to the patient's body weight. Now the body weight should be taken not the patient's weight, it should be an ideal body weight determined from his height, his or her height. Now there are different formulas for determining ideal body weight through height. It was initially devised in 1960s, which was a pretty simple formula, and nowadays the complicated formulas and different formulations take into account at times your actual weight, your age. But I think as a rough guide, if you don't have reception, as we don't have in our ED for the calculators, the rough guide is that the height in centimeters minus 100 for females and minus 110 for the males. And if that suits, otherwise if you can't even remember that, just height in centimeters minus 100 and start there, and then you can titrate up and down as per your floor time curve or as per the patient's PCO2 or PO2 or pH. There are a number of articles. The most recent ones are NOJAM 2000, Annals in Internal Medicine 2009, 2012 BMJ, and a Cochrane review of all the trials in 2013 that showed. This was the benchmark paper on ARDS ventilation that showed that lower tidal volumes as compared to traditional tidal volumes are better for acute lung injury or ARDS patients. So what were the benefits they saw? They saw that by giving low tidal volumes, you could lower mortality in ICU, in hospital, at 28 days and at 2 years, so extremely beneficial. Increase ventilator-free days. This means that people spent less days on the ventilator in ICU, even if the total stay in ICU was the same. Keep track of the volume dialed and delivered. So this is just an advice that you should keep track, that if you have dialed a volume of 500 but only 450 is going in, that might mean that something inside the lung has changed, and that is why the volume is not reaching what you intend to give, meaning thereby they could have gone into pulmonary edema, they might have got a pneumothorax now, or they might have been hemorrhaging inside and decreased compliance. So it depends that what has happened to the patient, what was the initial problem, but one should keep a track that what did you dial and how much is going in and why is it not going in. So there is a process that you should go through of reduction, that what might be causing this. Or simply it might not just be that the flow through the ventilator of the air is not enough to reach that volume, or the time in spot that you have given for ventilator to get that air in is too short. So all these things, so just to keep a track, and how to monitor this will go on further with the changes. Keep a track of flow time curves. So this will give you a good idea that what volumes are going in and whether they are going in an appropriate time manner, and what are the potential harms of low tidal volume. So low tidal volume essentially means that you are giving low volume, so your CO2 might go up. So hypercapnia is well tolerated in patients. It does no harm to them at all, especially if the pH remains above 7.1. If the pH drops below 7.1, then you need to introduce separate measures to control the CO2 rise, which may include temperature control, paralysis, shivering control, and decreasing the generation of CO2. That is essentially related all to intensive care, but from ED perspective, don't worry about the CO2 as long as the pH is above 7.1 and patient is oxygenating well and their pressures, peak pressures, are less than 30. Second thing, how much PEEP should we give? Now, what is PEEP? I haven't put that in there, but what is PEEP? PEEP is positive end expiratory pressure. It is the amount of pressure which should be kept at all times in the airways, from the ventilator to the tubing to the trachea to the lungs, all in one column. The dial PEEP means that certain amount of pressure, 5 or 10 centimeter of water, whatever you're using, will stay constant. How does that help? It prevents the alveoli from collapsing because it will keep that constant pressure inside them. So they are that much distended with the 5. When you give 500 of tidal volume, they will go up, they will go down, but they won't collapse because that's there. If you give no PEEP, what will happen? That they will collapse completely. Once they collapse completely, because they are lined by fluid inside, the pressure that you require to open up a balloon which is lined with water is huge. Well, what that could do, that could cause injury in other parts of the lung, because if you are bagging a patient who's got collapsed lungs with open lungs at the top, you're trying to distend or recruit the lower parts of the lung. The pressure that you are applying with the bag is getting distributed in all areas of the lung, not just in that collapsed alveolus. So the top part of the alveolus of that man, if that's weak, he will have a pneumothorax there, and this part of the lung will still remain collapsed. So this means that putting too much pressure and too much PEEP onto that might be dangerous. But if you don't allow the collapse to happen and give them appropriate stepwise PEEP, that would be hugely beneficial in recruiting more and more lung, giving you better oxygenation, decreasing atelectasis, and improving overall area which is involved in ventilation. Okay, that is why PEEP is important. Why we say that give a PEEP of 5 to everyone. So all normal airways with the glottis, with the pharyngeal muscles, with the air spaces, we usually have a PEEP of about 5. That's an estimate. Studies now, you can't really be sure whether after a couple of years you might say it's 8 or 4 or 3, but 5 at the moment is taken as standard as a normal. So everyone should have a PEEP of 5 because we are bypassing the normal passages which give you that PEEP. So everyone as a standard should go on to PEEP of 5 from ED perspective. Now, if someone has got APO and collapsed lungs from that, you will require a higher PEEP. So if someone has got an APO and their blood pressure is okay and they're tubed, give them a higher PEEP of 10. Okay? Some intensive cares, like Royal Melbourne, everyone goes on to a PEEP of 10 as a standard, unless there is a contraindication like a raised ICP or a low blood pressure extremely and they're struggling, they'll put it down to 5. Otherwise, 10 is standard. Now, there is a term called open lung ventilation. Now, what they showed in 95 with Gattinoni, 98, Amato, 2001, 2006, what does this mean? That by giving PEEP, you are keeping the alveoli open. That's where the term open lung comes from. It doesn't mean that you're doing a tracheostomy in ED and putting them onto a ventilator and it's an open lung. No, it just means that your open lung means that you're trying to keep the alveoli open as much as you can by giving a higher PEEP or an appropriate amount of PEEP. What are the benefits? It lowers your mortality, it improves oxygenation, it recruits lung, and it decreases alveolar overdistension. How it decreases alveolar overdistension? As the volume is shared by more open alveoli. For example, if alveoli at the bottom are collapsed and you are giving lower PEEP and only amount of air, only the alveoli which are taking exchange, taking part in exchange are the top ones, the bottom ones are essentially working as a dead space ventilation, and blood is going through, there is no oxygenation happening. So you need to give some amount of PEEP constantly, or increase that amount of PEEP so that gradually they will open. Once they open, what will happen, that the amount of volume will get distributed among the top and the bottom. So alveolar overdistension at the top will decrease. Okay? Now, and it will decrease, in turn, it will decrease ventilator associated lung injury, VALI. Now, so we have talked about volumes, we have talked about the PEEP. Now, there is another way of giving the volume. Now, in this, we were dialing up from 6 to 8 mils per kilo of ideal body weight. So if you're doing lung protective ventilation, you will give 6. If you're giving a standard person who is like a 21-year-old, comes in with an overdose of a drug, no known lung problems, gets due to decreased GCS, you give him general intermittent positive pressure ventilation strategy, which will be 8 mils per kilo. If someone is again 21, has got a viral pneumonia with bilateral shadowing, diagnosis possible ARDS, you give them lung protective strategy, which will be 6 mils per kilo. So there's a difference. If you think that the lungs are probably normal and hypoxic, it's just got a decreased GCS, you're tubing them, give 8 mils per kilo. That's the standard therapy. If you think someone has got ARDS, give them 6 mils per kilo with a higher PEEP. Okay? Now, there is another way of delivering the volume, because people have asked me before, should we give pressure control ventilation in this patient or not? So, 2 ways of giving volumes. One is by dialing up the volume itself, other one is by giving pressure. So now we'll go to the pressure. So pressure. So how does it pressure works? That essentially, if you see that if there is a piston in a car, and we'll ask the machine to give a certain amount of pressure onto the piston, and then it depends on the balloon at the end, that how much, what's the elasticity of the balloon, what's the compliance of the balloon, that how much it can distend under such an amount of pressure. That's essentially pressure delivered volume. Okay, so what's the safe pressure? So it's thought that if you give an inspired pressure of if you keep the peak airway pressures or mean airway pressures less than 30, it is safe. So what does that also mean? That you could give an inspired pressure of 30 and see how much volumes do they get. Okay, so the delivery of volume on that set pressure will depend upon the pathophysiology of the lung, will depend upon the compliance of the lungs from the injury that they have received. Okay, what we should aim at. If you give me 30 inspired pressure, my volumes would be more than 2 liters or something like that. A normal lung would have easily, with a inspired pressure of 15 to 16, they would have easily 500 to 600 mils of volume. Okay? There have been studies with Antonio Pacenti in 2007 and 2009 where they have shown that actually 30 is still not a safe value, because at 30 you're still over-distending some parts of the lung than the others, and if you decrease the volumes at 20 or 22, that over-distension is gone. So essentially what that's saying, that maybe further down the track in a couple of years we might be looking at further low downing the volumes from 6 mils per kilo, or inspired pressure of 30 to 22, giving a high PEEP so that it keeps it evenly distributed and open. Anyways, what's the downside of this? The downside of pressure control is that it does not give a assurance of minute ventilation over time, because the compliance is good at the moment when we tube the patient might be going into pulmonary edema, and the compliance might decrease 1 hour down the track. Now if the ED doctors or ED nurses are extremely busy and they can't keep track of what the volumes were delivered, and the standard alarm limits have not been changed to that particular patient, what might happen that the patient might go underventilated for a very long time before it gets realized, and that is extremely dangerous. That is why I think that what we should use volume controls in ED. Benefit of that is that it will guarantee a minute ventilation to that patient what you want, and if the compliance is getting worse, then the machine would alarm with a pressure cutoff value, because that pressure will reach. Now what should you set your pressures as? So now the second knob on the C3000 is, third knob is actually the pressure, airway pressure alarms limit gauge. So set 35 please, and leave it at 35, 30. What will happen that once, if the compliance is going down and you're giving 500 of molly volumes, it will alarm if it reaches that limit, and it will say, the alarm limit says that pressure limited, volume not constant. So pressure limited, it's a self-explanatory, volume not constant. What you could do, then you could do different strategies. Then you could decrease the amount of volume and increase the number of breaths to achieve the same minute ventilation. That's what usually people do. Or you can increase the amount of flows also by decreasing the time inspired, and that way you may be able to achieve the same minute ventilation what you were trying to. Or you can just tolerate the hypercapnia if you're reaching your limits, but by that time patient should be in intensive care. So I think I've explained that pressure control, just the very basic. We should not use it for the reasons that I've stated before. We should use volume control. Now this is a flow diagram. Now this limb is inspiratory limb, and we see that flow is high in the beginning, then it decelerates, then it touches the baseline. This means that the inspiratory time is good enough for the patient. And then there is a bit of a gap between inspiration and expiration, yeah? And then the expiration starts and it goes back to the baseline. This is what it should look like in a normal graph. Should we show it in the actual ventilator? Okay, so let's see. So here we see that there is a set amount of flow. So that's why the inspiratory limb is not decelerating. Yeah, and this is the expiratory flow, which is reaching the baseline. So inspiration is happening fine, expiration is happening. So you see the this is the pressure waveform with the alarm limit set at 50. Now this is not Evita, this is not C3000, this is Evita XL, but this gives excellent graphs. That's why we are explaining it onto this one. So let's see if we can change a few things.
So to clarify, that is square because it's not, there's no passive component to it.
No.
Is
So
that
we
right?
can make it, yeah.
That's right. So if this means there's a passive component, which is why it sort of tapers off.
Yes, and this also means that the autoflow is probably not on. I'll just check. Do you want to pause it for a bit when we do that? Or?
No, that's okay.
So autoflow was not on, so now I'll put on the autoflow.
Now, autoflow determines the rate of inspiration.
Inspiration, yeah. So there must be the deceleration flow. So there you go. So you see, once the autoflow is turned on, it determines itself that how it's gonna deliver the volumes within that. So it initially, with autoflow, it gives high flow of air initially, and then it decelerates. The decelerating
That's
flow.
the machine doing it, is it?
That's the machine doing it. So we can change it to a rapidly increasing, where this would become like this, which is the slope of the curve. So you see here, you see the ramp. So ramp means that you could ramp it up quickly. So there you go. So we've made it 0. So this, after making it 0, there would be a bit more acute now. So if you compare these two, this is a bit slant, this is a bit more acute, this is a bit more acute. So this is just determined from this. Previously, when the autoflow was not on, that's why there was a square wave, and now there is a decelerating wave. So autoflow should always be on all ventilators.
So it's not to do with passive inspiration or expiration.
No.
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 It's to
Inspiration.
do with the machine determining how the air flows.
How the air flows.
Okay.
So inspiration will always be
Mechanical.
in a patient who is paralyzed,
Yeah.
and expiration would always be passive in a ventilated patient. And expiration time would always depend upon patient's pathophysiology and how much time does it take to expire. For example, if this patient has got normal lungs, he's expirating and the flow is finishing here, this means that the volumes that we are dialing 520, the expired volume VTE is 520 as well. So that's excellent. Whatever we are dialing is coming back to us.
Yeah.
And we are seeing that in a graphical format in the form of expiratory flow. Okay? If someone is asthmatic, what will happen? That this expiratory flow will not finish before the next inspiration begins. So let's create that scenario now while we are here. What we could do, that we could increase his respiratory rate oh, it is not. Not sure why it's not changing the thing. So, okay, so it's changed now. So what we have done, we have just increased the rate to see that how the expiratory flows looks like. So if you see the expiratory flow here, it's not finishing fully. So this means that by every breath, he's going to stack some mils in the chest. So with this, every breath as he will take, his total lung volumes will become higher, higher and higher and higher, and eventually he's at risk of barotrauma, he's at risk of pneumothoraces, pneumomediastinum, ventilator-associated lung injury. And in asthmatic people, they will have auto-PEEP as well. And we'll talk about PEEP in a moment in the asthmatic people, but just for the normal ventilation in a normal lung, we should always have a look at the expiratory flow curve. It should always finish. Now, how we could make this finish in time? What we could do, that we could decrease the time inspired. So if you see the time inspired here is 1.7 and the IE ratio is 1:1, which is usually bad. So we should decrease the time inspired. So confirm. So we are decreasing the time inspired. As we are decreasing the time inspired, the IE ratio is getting better from 1:1 towards 1:2. So let's make it 0.95. Oops. Okay. So all I have done, that I've improved their IE ratio. Previously it was 1:1, now it's 1:2.6. I've done that by reducing the time inspired, and see what happens to their expiratory flow, and the expiratory flow has reached the baseline. So that's what we are aiming at. Okay. So if in the inspiratory flow that doesn't return to 0, this means that you may not be giving enough time for the air to flow in during inspiration. So you might make the inspiration a bit more longer. Okay. This is the graphical representation of what we were seeing before. But if you have such a patient, you can easily see that there is a huge distance between inspiration finishing and expiration starting. So you could easily turn down that inspired time without compromising the inspiration at all. Yeah?
Yeah.
Now, this is just showing someone with an asthma. Just disregard this part. What's happening here, that this dotted line should have been the normal expiration, whereas the patient's expiration time is taking way longer because the airways are small and they are breathing through a very narrow hole and having a very prolonged expiration. So we should always look for that. We should treat that by bronchodilators or anything you like, and we should allow them enough time so that they can expire fully, so that their lungs don't balloon up. Okay. Do we need to go through that? I don't know, but just quickly, this is the volume graph, that the volume goes in, volume comes out. This is inspiration from here to here. This is the pause, and this is the expiration. Okay. Now, this is the flow time curve without autoflow. That's the square box. That's the decelerating flow. Okay, with autoflow on. And this is expiration in the both. Make sense? And there is no flow when there is inspiration, expiration is the same. So this is the area where there is a pause. Okay, and you can see in the pause that the volume remains the same. Okay, and the pressure remains the same as well. Now, see the big difference in the pressure waveform. What happens in the pressure waveform without autoflow, that the pressure goes up quickly to overcome the resistance of the airways, and then it becomes constant once the lung is inflated and the air has gone into the alveoli. So this peak pressure would always be higher than the plateau pressure because of the resistance airways. So if someone has got asthma and you put them onto without autoflow, the graph will look like this, that it will go up, high peak, then it will fall down. And then the plateau would be normal, because beyond the obstruction the lungs are normal. Okay? This means an asthmatic would have a large difference between their peak pressures and their plateau pressure. There would be a large difference. This is in comparison to a patient who has got ARDS and low compliance. In a patient with low compliance, the plateau pressure will go up as well. Okay, so the difference between the peak and the plateau would be the same as in a normal patient or less. Okay, but the difference between the peak and the plateau in a patient who's got asthma would be huge. So by just looking at the pressure curve, you could tell that this patient has got asthma. Now I'm talking about the usual people, like commonalities. Okay, you could be able to tell this patient has got asthma or has got ARDS. So he's got a compliance problem or a resistance problem. Okay. The problem is that you lose this sort of technical information or academic information, one could say, which may not impact any outcomes when you put autoflow on. That's one downside of autoflow, but it's got huge benefits. So because it regulates the flow through the pressure, autoflow, what happens is that it smooths it out. Make sense? So you won't see the peak and the flows. The rest is all story. So this is just to explain the same thing. So if the compliance, this is normal. If the compliance goes up, the whole thing goes up. So the difference in the peak, the delta P, would remain the same. This is compliance problem. Okay? Now this is resistance problem. So there is a huge resistance to overcome the airway narrowing, and then the plateau remains the same as the normal, which is shown in green interrupted line. Yeah. Now what happens if the ventilator is alarming that pressures, and you see this sort of undulation? This means that patient is trying to breathe. Okay? In emergency, I've seen it more than many times, that if the ventilator is alarming due to pressures and the patient's actually showing these undulations, it's hugely difficult to just keep increasing sedation and trying to overcome a young man's breathing stimulus. It's probably best to decrease the sedation so that they can breathe up enough to maintain their breathing patterns and to maintain their oxygenation and CO2. So when the ventilator is alarming like that, and otherwise everything looks good apart from the ventilator and alarming, what you could do, and the chest movement of the patient is just haphazard and there's no sense to it, what you could do, decrease the sedation, do not paralyze them. I repeat, do not paralyze them, do not increase sedation. Just put them onto very low rate of SIMV or put them onto pressure support ventilation, spontaneous mode. So spontaneous mode in an intubed patient. That will mean that they will just get bi-level pressure support. They will get PEEP, they will get pressure support, they will breathe for themselves, which is the most physiological and excellent amount of breathing. Okay? By physiological I mean the or usual system is that there is negative pressure in the pleural space and air goes in when we take a big breath in and then it comes out, whereas with the positive pressure ventilation we're pushing actually urine. Okay, sweet. So this is just a rehash of what we have said, how to set up a ventilator. So I should have omitted this. Choose volume control. Suggest volume control in ED as it guarantees minute ventilation and does not require expert nursing, and staff are familiar with the mode. Suggest start at 6 to 8 mils per hour, 8 mils in a person with normal lungs, 6 mils for ARDS. Follow the hospital protocols, please, with ARDS net ventilation. They are available on every server. Choose rate. The best time is at the beginning when the patient is deep or paralyzed. Why is that? Because it gives you absolute good compliance without absolute good indication of patient's compliance of the lungs without any muscle interference. So choose a rate of 10 to 14, see what volumes they are getting, see their expiratory flows, so you will get an idea where you are starting from. Okay, there is no right or wrong rate, there is no right or wrong volume as long as you are in the same ballpark according to their ideal body weight. You just have to titrate your rate and your volume and your minute ventilation with the patient's illness and their requirements. Okay, IE ratio, aim at 1 to 2.5 in a normal person, 1 to 3 or 4 in asthmatics, or even 5. Now, what is normal minute ventilation? So, some book says that about 110 mils per kilo. So 5 to 10 is the usual what one should aim at. I would usually start initially at 8, and if I need to work my way up, I'll work my way up, or down then down. So set flow volume curve and optimize your time inspired according to expiratory curve. Optimize your rate according to expiratory curve. Optimize your tidal volume if you can't do anything with these two after consultation with another senior person. That can you decrease the rate because the patient is still air trapping. Okay, now we go on to the PEEP. So we have discussed PEEP before. These are just suggestions that if patient has got asthma, give them low PEEP. Give them low PEEP. Why? Because asthmatics can't expire fully. They develop auto PEEP, and we should give them low PEEP so that our PEEP does not increase their auto PEEP and does not contribute it to trauma. If patient has got no head injury, you can give them a PEEP of 10 to protect the lungs from collapsing, especially if they've got traumatic lung injury. If they've got head injury, give them low PEEP because higher PEEP will raise ICP if they are hypoxemic for any reason. For example, if they've got pneumonia, ARDS, medical reasons largely, give them a higher PEEP, 10 or 12 at least. Okay, FiO2. So oxygen harms at the start if they're hypoxic with 100%, but when you know that they are stable, they've got excellent oxygenation at 100%, reduce them to less than 60 or 60. Okay, peak airway pressures, select 35 or 30 if you like, but don't go above 35. We know that above 30 is dangerous. There is an indication that we might reduce it further in future, but at the moment 30 to 35 is good. Trigger. Now what is trigger? Is it relevant to ED? I'm not sure, but because it's a setting on the C3000, I'll just go through it. So trigger is when someone is breathing by themselves and the pressure support needs to be given by the C3000. It detects the patient's flow of air when they're trying to inspire. So you can set it down to 1. 1 is extremely sensitive. And what does that mean? That if the flow sensor detects that there is 1 liter per minute of flow, patient is trying to inspire, it will give patient an inspiration depending on what pressure support you have given. So if patient is trying to take a breath in, machine will detect it because of the trigger that you have set, and it will give, let's say you have set up pressure support of 5, it will give 5 centimeter of water pressure when they're trying to inspire, so it will become easier for them to take a breath. If you set the trigger too high, 4 or 5, now what's happening, that patient is trying to take a breath, machine is not giving the breath because you've set the trigger too high. So please don't do that. Make it easier for the patient to take a spontaneous breath, so keep it low. How low? Probably 1. I don't think you could set to 1 in C3000s, probably 2. If you set to 1, it might become too low, and anyone auscultating chest, putting their hand on the chest, or any sort of motion, or even sometimes a very high heart rate can oscillate the air inside, and it could cause auto-cycling, that the heartbeat and the fluctuation in the wave of air will read as a breath, and machine will not give a mandatory, but it will await and try to give a pressure supported breath, whereas patient ain't taking a breath. So probably I think 1 is too low, set it to 2. Alarms. Now there was a problem in the past with C3000s. I don't know whether we had our software upgrade, but if there is no alarm and the patient is hypoxic, this was a huge problem when these ones came out, that the pressure supply was low. What do I mean by that? That the oxygen has finished in the tank. We should realize that these machines can't run without a pressurized air source, whether it would be pressurized air, whether it would be pressurized oxygen. These machines require constant pressurized source. These can't run on air. So if the air is finished in the cylinder, or the oxygen is finished in the cylinder, the machine will stop. Or it won't alarm, or if it would alarm, it might be just an empty line saying an alarm, or it might say low pressure alarm, which might mean that there is a low oxygen supply or there is disconnection. And once the oxygen supply is low or finished, it will essentially stop ventilating. Okay? So you need to change the cylinder if you're not sure what's happening, or if there is an abnormal alarm that you see on the thing. Battery low is again a big problem. If you are going for like a CTA or a chest abdo-pelvis head CT with contrast, it's probably best to take the power source with you and plug it in, rather than depending on the battery. And the battery will usually last good half an hour, but if the thing is old, as you know, the mobile batteries don't last that long when the mobile is old, so these won't last that long either. Now, if it says pressure limited alarm, then either the patient is breathing against the ventilator, they are not paralyzed anymore, or the ETT is blocked, or there is a pneumothorax or something like that. So just go through the stepwise approach from top to bottom, that why the air is not being delivered and why it's pressure limiting. Now, just a rehash of all the things which we have said. In asthma, COPD, avoid intubation if possible. Early large ETTs, if you could put. Why a large ETT? Because adding a smaller size, like a size 6 ETT to a asthmatic patient is just going to be more resistance to the tube. So the larger you can put in, the better it is. Minute volumes, so less than 115 mils per kilo. So for just a rough estimate, for a 70 kg idle body weight, 8 liters. Just give you an idea, between 6 to 10 you can manage. Tidal volumes, less than 8 mils per kilo. So this is general intermittent positive pressure ventilation strategy. Again, respiratory rate low, as long as patient can tolerate. Allow them time to expire. Allow increased expire time, the same thing again and again. Peak pressures, plateau pressures less than 30. Maintain airflow rate. So now this thing is important, because if someone has got tight narrowing, you want to increase flows so that you could go through that narrowing, okay? Because you've got limited time on inspiration, because you also have to extend the expiration. The two ways of doing it. If you can play with the flow, you can play with the flow. That's excellent. You can just titrate up the flow to 80 to 100 liters per minute. But if you can't, then on C3000, you have to decrease the time inspired to increase the flows because you can't set it separately. Okay? Just remember that bit. Whereas on Oxylog 3000 Plus, when you turn the machine on, the default is that the autoflow is off. So you need to go into settings, I think it's page 3 or 4, and then you turn on the autoflow. Okay? That's extremely important. Whenever a patient is intubated and ventilated, turn on the autoflow. Turn on the autoflow. How would you remember, how would you see that if the autoflow is not on? So see the inspiratory waveform. If it's a square wave, it's likely that the autoflow is not on. Okay? Sweet. So, allow hypercapnia for patients with high peak pressure. So if you're reaching your limits with above maneuvers and the patient is still hypercapnic, you can't do much, just let them be hypercapnic. You can do a lot of things, like you could do sevoflurane, anesthetic circuits, ketamine, stuff like that, but medical management. But in ED, just get the patient down to ICU as quick as possible. If patient is improving and starts breathing spontaneously, in an asthmatic patient, it's probably the best thing for them. Let them breathe spontaneously if they're doing well with it. Okay? Because then they won't trap that much. Yeah, because if they're breathing spontaneously. Okay. Dynamic hyperinflation, this is the same term as autopeep. This is the same term used for air trapping, which I was trying to explain before with expiration times. Trauma. Trauma is a hugely difficult problem which involves hemodynamics, lungs, brain, tummy, all working against you and all limiting your potential to play with the ventilator. Okay, we'll go through them one by one. Avoid hypoxia at all times, avoid hypotension, avoid hypercarbia, because this will increase the ICP. This is extremely important for, again, cerebral perfusion pressure. Hypoxia, again, extremely important for all the vital organs. So if you have to sacrifice any of these, first one this will go, second one this will go, third one this will go, but avoid to maintain them as normal as possible. Goals are achieved with aggressive or appropriate should be used, volume resusc and blood products. Oxygen and appropriate PEEP. Why I say appropriate PEEP here rather than high PEEP? Because if someone has got a head injury, you don't want to give them high PEEP because that will raise their ICPs. Okay, so aim at a SATs of greater than 1992 and titrate it accordingly. Appropriate minute ventilation to aim normal carbia. So you can increase their minute ventilation by increasing the respiratory rate or increasing the volumes, but don't go up in the volumes from 8 mils per kilo and start increasing the rate and decreasing the time inspired to achieve normal CO2. A journal strategy. What a journal strategy means, 8 mils per kilo, not 6 mils per kilo, so that you can take care of normal carbia. Otherwise, if you give 6 mils per kilo as lung protective ventilation, there would be hypercarbia affecting the brain. Okay. Hemorrhagic shock, give low PEEP. If someone is bleeding and they are hypotensive, give them low PEEP. The reason is that if you give them high PEEP, there would be decreased preload to the right side of the heart, and then in turn the left side of the heart would decrease output, so low BP. So essentially, decrease the PEEP if someone is bleeding massively, especially from the limbs, or they are hypovolemic, because if they are already hypovolemic by increasing pressures by increasing intrathoracic pressures, you won't be helping the right side of the heart. Okay, so fill them up, then you can increase the PEEP or play with them when you think that you have controlled the hemorrhage. Now, thoracic trauma, lung contusion, just manage them as you would manage any ARDS patient. Why I say that is that essentially they have got a compliance problem with hemorrhagic infiltrate or any sort of traumatic infiltrate inside the lung, giving them low lung compliance. So there is no resistance problem in these people, and there's poor lung compliance due to the injury. Now, they are at risk of barotrauma because you would require higher pressures to achieve certain volumes. Use high PEEP, use lung protective strategy, allow permissive hypercapnia if you're reaching the ceilings of use. You can use ARDSNet protocol if you like. Make sure no coexisting brain injury. So, because if there is a coexisting brain injury, brain will take preference and high PEEP might make it worse. So just make sure that there is no traumatic brain injury before you embark onto strict strategies with the ventilation always. Okay.
Now, if someone has got an isolated head injury, cyclist versus car, no other injuries found, it's got an open fracture or something like that, then what to do? So aim is to optimize cerebral perfusion, optimize oxygen delivery, trust no one, give oxygen, maintain cerebral perfusion. Now, this is achieved by avoiding lung protective strategy. So rather than this, we should have written here, use general lung strategy, which is 8 mils per kilo rather than 6 mils per kilo. Avoid hypercapnia. That's extremely important, because as your CO2 increases, cerebral vasodilation happens and the net blood volume in the head increases, so potentially increases ICP. So aim normal carbia, aim PaCO2 of 35 to 42, because if you make them hypocapnic, that will cause cerebral vasoconstriction and it will impair blood supply to areas which might already be under threat. Okay, this has been shown in 91, 2005, 2005 again. So prophylactic hyperventilation causes harm and should be avoided. So hyperventilation reduces cerebral perfusion immediately following injury when cerebral flow is already compromised, causing ischemic stroke or injury. Okay. Only exception is when you think that someone is herniating and then you are going to theatre and you think that it will be only for a very short time. You have already, this is already accepting that you have sedated them, you have used your osmotic therapies, he's paralyzed, patient is on cisatracurium infusion or rock infusion if you like, and you're doing a planned CSF drainage. Hyperventilate them by all means. Use hypertonic saline or mannitol as per your institution guidelines. If hyperventilation is instituted, it should not extend beyond a period of 1 to 2 hours while awaiting OT. Okay, so this is not some sort of a strategy for days and days to come. This is a short-term strategy where you're making decisions, where you're arranging things. Okay, because eventually it's going to harm the patient. And if you've got nothing to do and patient is a non-operative candidate and the injury is beyond control, then you should be discussing with the neurosurgeons and with the family that what should be the next course of action. Now, what if someone is pregnant and comes to your ED and requires a tube? It's a disaster, isn't it? So what we should know what the normal is. So the normal is respiratory alkalosis with a pH of 7.4 to 4.7 and a CO2 of 32. So our target CO2 in intubated pregnant women should be 32 to 35, which is different from a normal person, which is 35 to 40. So animal studies have shown that further lowering the CO2 reduces placental blood flow because it causes constriction. Okay, so do not reduce your CO2s any further than that. But on the other hand, what if due to the gravid uterus, intra-abdominal pressure, the pre-existing pneumonia, the splinting of the diaphragm, you cannot achieve volumes? If you can't achieve volumes, you would be hypercapnic, won't you? So permissive hypercapnia does not affect the fetus. Now there have been few studies on this and they've tested it up to about 60. So up to about 60 they are sure, above 60 they're not sure. So I think permissive hypercapnia can be allowed in extreme situations without causing harm. Like if you keep increasing the pressures, keep increasing the volumes, you might cause a pneumothorax, you might cause pneumomedastin, you might cause ventilator-induced lung injury. So rather than causing all those things, probably tolerate a bit of hypercapnia and get expert advice how to manage the patient better and get the baby out early so that your lungs would behave in a normal manner. Now, these people need high PEEP to prevent basal lactases because tummy is pushing from below. Okay, I think that's fairly self-explanatory. So this is just a slide showing you what do we mean throughout the slides by giving general or lung protective positive pressure ventilation. 6 mils per kilo, 8 mils per kilo. Rough guide 12 to 20, 14 to 16. Rough flow guide 60 to 90. Now PEEP 5 usually high 10. Now this is just a extremely rough guide. This is no by means a protocol. stick a patient onto whatever you think is appropriate, then go and re-examine them, go and re-examine their blood gas and titrate accordingly. Okay, this is just to give you a guide where to start from. Okay, and use ARDSNet protocol for this sort of thing, whereas these ones just use this and then the patient how they respond to this and what their lung compliance is like.
Just can I clarify the flow there? You're referring to?
So if you are decreasing the time inspired, the flow will go up. Okay, but if some machine doesn't have auto flow, and you can set the flow separately,
Which we can't do, can we?
we can't do no.
No.
You can in the C1003 Plus.
Right.
So then the rough guide is 60 on the general and 90 because you need higher flows because you have decreased your time inspired and you're giving more expiration time in lung protective ventilation, so you need higher flows. Yeah. Whereas with the auto PEEP and with Evita XL or with big ICU ventilators, they do this job really well rather than the C3000s. Take home message: think exhale, because exhalation is the most important part of the ventilation for the patient and to do no harm. Optimize tidal volumes. Always think if you're changing something, could you be causing harm? If you think in that way, you probably will remain to more conservative management. Optimize PEEP. Reduce FiO2 to non-toxic levels and do the best thing by the patient. So increase their head end to 30 to 40 degrees if you can. If the patient is a trauma patient intubated with a hard collar, make them in reverse Trendelenburg position or Trendelenburg position, like this, like a board. Okay, so that you elevate their head. So this is Noam Chomsky, Education as a System of Imposed Ignorance, rightly so. Thank you very much. Thank you.